Thank you. And I'd like to begin by thanking the organisers for the kind invitation to speak today. And the topic we'll be covering is atypical thyroid function test. And what I hope to show you is an approach which will allow you to work out whether indeed apparently anomalous results are indeed something or nothing. I will begin with my disclosures. I have nothing relevant to this particular talk. So when I'm thinking about thyroid function test anomalies, I like to consider them under three major categories. Conditions which arise as a consequence of pre-laboratory factors, typically because we as the clinicians have paid insufficient attention to the clinical context. Maybe we haven't thought about the potential variance in TFTs that we might see with age or in the context of pregnancy, or the effects of compounding medications or non-thyroidal illness, or indeed even in patients on thyroxine replacement. There's a whole multitude of issues that we will see shortly that can cause problems with how we determine and measure free thyroid hormone and TSH levels. Or it may be that we're not particularly familiar with some of the rarer genetic or acquired disorders that can produce these unusual results. I think it's always helpful to be able to think about thyroid function test patterns. So these are the typical ones that we're very familiar with: normal thyroid function test, or indeed typically thyrotoxic or hypothyroid patterns of free T4, free T3, and TSH. But it's worth bearing in mind that there are some other patterns. So for example, we may see scenarios in which free T4 and free T3 are normal, but the TSH is actually low or indeed fully suppressed. Or alternatively, the free T4 and free T3 are normal, the TSH is raised. And these are just some examples of the conditions that can produce these patterns. Equally, we may see free T4, free T3 levels are low, but the TSH is not elevated. It's either inappropriately normal or indeed low itself, or the free T4 and free T3 are raised and the TSH is not suppressed, but inappropriately normal or indeed elevated. And again, some potential examples of these are shown here. So what I want to do today is to use the example of raised thyroid hormones and non-suppressed TSH to show you a strategy for sorting out the potential different causes. And as always in clinical medicine, we need to begin with a good review of the clinical context, then consider the potential factors that might be causing laboratory assay interference, and then moving on to consider specific rarer conditions. So if we begin with step one, it's important to revisit the history and the physical examination, determine if there are any interfering illnesses or indeed medications, and also work out whether you think the patient's broadly hypothyroid, euthyroid, or hyperthyroid. And this just helps to serve as a reminder that we do need to bear in mind that there are variations. For example, in age-specific reference ranges probably should be considered here. We can see that TSH does tend to rise even in individuals with no thyroid disease as we age. We also will be very familiar with the context of variations in total and free thyroid hormone levels and indeed TSH during different stages of pregnancy. There are a whole multitude of potential conditions that can produce abnormal thyroid function tests in patients receiving thyroxine therapy. We need to work through these systematically before we often are left trying to determine whether a patient has an issue with adherence to medication or indeed absorption. And then, although many people are aware of potential effects of drugs such as amiodarone on thyroid function, often left appreciated are the effects of drugs such as heparin. This is obviously very commonly used, and it can produce disrupted thyroid function tests by activating endothelial lipoprotein lipase, causing hydrolysis of triglycerides, release of free fatty acids, and displacement of T4 and T3, which really produces a problem, as it were, in the blood tube itself, rather than actually making the patient genuinely hypothyroxinemic. But it can be a problem that if the sample is not processed quickly and efficiently, can appear to become more of an issue as time passes by. Now, once we've actually considered all those and we've excluded any potential interfering illnesses or medications, etc., we then need to turn our attention to whether there is a problem with the measurement made within the laboratory. And as we'll see with some examples, there are a whole array of different conditions that can cause issues when trying to determine TSH and or free T4 and or free T3 levels. And I'm going to use some illustrative cases to highlight this. This was a patient referred to our service, 72-year-old gentleman by his primary care physician. He'd had stable primary hypothyroidism for many years. His past medical history included hypertension and aortic valve replacement, for which he was on these medications. By the time he was actually referred to our service, he had some features to suggest he was mildly thyrotoxic. And these were the initial TFTs, which had actually triggered the concern from the primary care team. So having had normal thyroid function for many years, the TSH was now raised, albeit with a free T4 towards the upper end of the reference range. And this had precipitated a repeat sample, which had confirmed very similar results. I guess the question is, what should we be thinking about next? Well, in a patient where there is clearly a long history of likely thyroid function test results that you could review, it's worth going back to check these. And you can see that for the most part, on a reasonable standard replacement dose of thyroxine, the patient had normal TSH, but unfortunately, at the time just prior to referral, there was a quite significant change, as you can see, with no change in thyroxine dose, but now the TSH being significantly elevated. In fact, the GP had actually changed the thyroxine dose, gradually up titrating this, but unfortunately, this had no effect on the TSH, which, if anything, was climbing further. But as you can see, the free T4 level was actually also rising, and indeed, by the time the patient actually was referred to our service, they actually had overt features of thyrotoxicosis. So the question is, what should be done next? And in this particular case, this was actually readily resolved by actually sending a single blood sample to 2 different laboratories with 2 different assay platforms. And you can see that the results are very, very dramatically different. In platform 2, we have a completely suppressed TSH with the phrase free T4, which is very consistent with the symptoms that the patient now had on the increased dose of thyroxine, and very different to those original assay results, which were clearly therefore erroneous. And this patient had interference in the TSH assay, which you will remember is a classic sandwich assay, so a capture antibody with the TSH in the middle and the detection antibody with the signal. And it is possible to get interference in this assay, for example, by the presence of petrophilic or anti-animal immunoglobulin antibodies, which are capable of cross-linking the capture and detection antibodies, even in the absence of TSH, to give a false positive readout. The opposite is also true, where we can actually have antibodies which block the binding of the TSH either to the capture or detection antibody, and therefore prevent the sandwich from being formed. Now, indeed, there are other ways in which the TSH assay can also have problems. I'm going to use a slightly different case here to illustrate this. This was a 7-year-old child who was detected to have a markedly elevated TSH on the blood spot post-birth. Now, there's no real concern in the pregnancy or in the labor itself or in the early postnatal period, but you can see the TSH was markedly elevated. And actually, when it was repeated 4 days later, it was even higher. And that caused sufficient consternation that the child was started on thyroxine. But actually, that didn't improve things in so much as not only did the TSH remain elevated, but the free T4 and the free T3 now rose and were associated with a jittery thyrotoxic child. The question is, what's going on here and what should we do next? Well, in the interests of time, I'm just going to show you the thyroid function tests from the mother, which interestingly show a very similar picture to the child at birth with a markedly elevated TSH with normal free thyroid hormone levels. And this is accounted for by transplacental passage of an antibody, which has actually caused macro TSH to fall. So this is another form of interference in the assay. On this occasion, the immunoglobulin binds to TSH, but it binds in such a way that it leaves it still able to bind to both capture and detection antibodies, so it has immunological reactivity still, but actually the presence, obviously, of the immunoglobulin bound to the TSH prevents it from being biologically active. So this is indeed a form of assay interference. Again, when we look for problems with the TSH assay, we need to keep in mind presence of potential heterophile or anti-animal immunoglobulins, possibility of macro TSH. Other phenomena have also been reported, such as the presence of paraproteins interfering with the TSH assay. A patient here who on hospital admission had a detectable paraprotein with a markedly elevated TSH level, which actually then disappeared as the paraprotein disappeared. We can also see other rarer reasons why the TSH assay may not be behaving itself. So, for example, here is a very unusual variant of TSH beta subunit in which the mutation renders the TSH immunologically undetectable from a standard assay, even though biologically this is still active. How do we exclude assay interference? The key message is to talk to your laboratory, and they can perform a whole number of different studies, TSH dilution studies, PEG precipitation to remove interfering immunoglobulins, or gel filtration chromatography. I did actually show you how comparison across assays can be helpful, but I would urge on the caution here, because this is not always a reliable way. You can have assay interference across multiple assays. Dilution, as I say, is something which can be easily done. Here's a patient with standard hypothyroidism in which their serum is diluted, and we can see that as we dilute and back multiply by the dilution factor, it's pretty consistent. But here's a patient with assay interference. We can see that as the dilution occurs, the weakly formed heterophilic antibodies, the weakly cross-linking heterophilic antibodies here actually dissociate, and therefore the back multiplication does not hold true, and we see a decline in that TSH level. Here is gel filtration chromatography showing that normal TSH comes off, obviously from the column, at a very different place to CSH, which is actually bound to immunoglobulin. I'm going to move on now to a different consideration from an assay perspective. This was a 35-year-old lady who presented with a number of features that suggested hypothyroidism, but actually interestingly had a history of palpitations in the past. But the TSH was markedly elevated, and the free T4, however, was actually also elevated. Thyroid peroxidase antibodies were clearly detectable, whereas TSH receptor antibodies were not. So what should be done next? But in actual fact, when this patient had a blood sample taken and sent to 5 different laboratories running 5 different assay platforms, you can see dramatically different results in the free T4 assays, but a very consistent elevation of the TSH, suggesting the patient really had genuine hypothyroidism. But in the free T4 assays, depending on where you sent the sample, the patient was either thyrotoxic, euthyroid, or hypothyroid. And clearly that cannot be true. So we just need to remind ourselves of the structure of free T4 and free T3 assays. So most laboratories are using a one-step platform whereby a fixed number of binding sites for endogenous T4 or T3 are occupied either by the endogenous T4 and T3 or a competing analog. Now, of course, we know exactly how many binding sites there are, and we know how much analog we add. So the greater the amount of endogenous hormone, the less the analog is going to bind. Once we have the enhancement solution, we get a fluorescent signal, which is therefore inversely proportional to the amount of endogenous hormone. How can this be perturbed? Well, if anything disturbs this equilibrium, such as altered binding capacity for T3, T4, and therefore T3 or T4 analogs, such as variations in albumin or anti-iodothyronine antibodies, well, they can perturb that equilibrium, so we can end up with a false result. And this will give a false positive result by removing the analog, which would suggest there's more endogenous hormone. One way to get around that is to use a 2-step assay. We introduce a wash step, which essentially keeps the patient's serum and the immunoglobulins therein separate from the analog, which is then back titrated. And in fact, in this particular patient, all the erroneous results for the free T4 were based on 1-step assays, and the correct results came from 2-step assays. So it's worth bearing in mind that the same result in different hands could still be the wrong result. And just for completion, we performed dialysis, which showed that this patient had a genuinely low free T4 level. And this was not due to variation in albumin or familial dysalbuminate hyperthyroxanemia, but instead was due to the presence of anti-iodothyronine antibodies. The patient had primary autoimmune hypothyroidism with free T4 assay interference. Just to mention FDH, of course, is a genetic condition with variations in the albumin gene, but it's a genetic condition which produces problems with laboratory assay measurement. So albumin has 4 different binding sites for T4 and or T3. And actually, if we look at one of these binding sites much more closely, we can see there are a number of key residues, arginines, which line the pocket into which the thyroid hormone can bind with their side chains projecting in. Once the thyroxine is in there, it displaces these side chains. But if we mutate one of these side chains, then the pocket can become a little bit more accommodating to T4 or indeed T3, and therefore we increase the capacity for albumin to bind to these sites. And again, we reported a few years ago now how very many of the assays which are commercially available, indeed not just 1-step, but actually rather frustratingly a number of 2-step assays, were subject to interference in families with genetically proven FDH, with varying degrees of interference, even among family members from the same kindreds. And some of the assays were really very prone to give abnormal results, whereas others would sometimes return normal results. So the likelihood of observing interference in the different assay types does depend on the type of interference. 1-step assays are vulnerable to many of the factors that I've described. The 2-step assays generally tend to do a little bit better, but they are still prone to some degree of interference, whereas equilibrium dialysis currently is considered to be the gold standard. Just a word for a moment about biotin. Biotin is both used as a healthcare product, but it's also used in medicine, for example, to treat inborn errors of metabolism, or also, for example, in some patients with multiple sclerosis. However, as well as the other forms of assay interference that I've shown you, such as heterophilic antibodies or macro TSH, it's also worth checking whether the assay that you're using depends on the formation of the streptavidin-biotin complex to fix the immunoglobulin to which the analyte is measured, is binding to the bead, for example, in this case. And biotin is a key component of that biotin streptavidin complex. Now, if free biotin in the serum is able to actually occupy these binding sites, then it may actually prevent the formation of this complex between the immunoglobulin and between the streptavidin. And that can therefore produce a TSH result which appears to be very low. At the same time, biotin actually, in assays of thyroid hormone measurement, can actually interfere with the ability of the assay to detect, for example, analog binding to the bead, and therefore if there is no apparent analog, the assay will assume or be interpreted as indicating there's high levels of endogenous hormone. So you can actually almost get the perfect storm with biotin, whereby you have raised free T4 levels apparently, but low TSH, mimicking classical primary thyrotoxicosis. And therefore it's important to know whether your assay is susceptible to this. So once we've excluded laboratory assay interference, then we need to be able to consider specific conditions, either conditions that are associated with raised free T4, conditions which are associated with raised free T3 and with abnormal T4-T3 ratios, or indeed conditions associated with raised free T4 and free T3. Now, in the interest of time, I'm just going to focus on this group at the bottom here, and in particular, trying to distinguish between RTH beta, resistance to thyroid hormone due to mutations in TR beta, and TSH secreting pituitary adenomas, thyrotropinomas, or sometimes known as TSHomas. So I'm going to use a couple of patients just to illustrate how tricky this can be. These patients were referred to our service around about the same time as each other. Both had palpitations, but one patient also had galactorrhea and oligomenorrhea. You can see reasonably comparable thyroid function test results, both with raised free T4 but non-suppressed TSH. But one patient had a raised prolactin and one patient had a normal prolactin. Now, the MRI in the patient with the hyperprolactinemia clearly showed an abnormality with this high signal area non-contrast T1 spin echo MRI, suggesting a structural lesion in the pituitary, whereas the patient with the normal prolactin had, for all intents and purposes, a normal MRI. So if I ask you to declare which patient you think is going to have the thyrotrophic tumor, I suspect it's likely to be case number 4, whilst case number 5 is likely to be considered to be most likely to be RTH beta. However, of course, ironically, the patient who has the structural lesion in the pituitary was subsequently shown genetically to have a mutation in TR beta and also an incidental microprolactinoma, whereas the patient who had an apparently normal MRI was subsequently found to have a thyrotropinoma. So again, it's very important that we don't just make assumptions when we meet these patients, because that could lead to inappropriate investigation and treatment. So just to summarize the differences between TSHomas and RTH beta, but equally also the overlap, the first thing to say is it's very difficult to separate these based on free T4 and free T3 measurements. Both conditions produce elevated results, but as you can see, there is considerable overlap. Here we're showing results from patients with proven TSHomas denoted by the red circles and patients with genetically proven RTH beta shown by the green triangles. Equally, it can be extremely difficult to separate the two conditions based on TSH levels. TSHomas may have a tendency to occasionally have higher TSH levels, but in many patients, these TSH values fall within the appropriate reference range or only slightly elevated, as can be seen in patients with RTH beta. Sex hormone binding globulin is a liver-expressed protein which is sensitive to thyroid hormones, and for a long time it was considered that it was going to be raised in patients with TSHoma and normal in patients with RTH beta, because the TR beta isoform, as well as being expressed in the hypothalamus and pituitary, is also expressed in the liver. But we have been able to show that unfortunately there is considerable overlap in SHBG levels between patients with RTH beta and TSHomas. And actually, it's interesting that many of the patients with micro TSHomas seem to often have SHBG levels which are within the normal range. And this holds true whether we're looking at premenopausal, postmenopausal, or in females or indeed males. One of the investigations which does seem to separate out between the two entities quite nicely is the serum TSH response to intravenous TRH. And you can see in these two cohorts of patients with proven thyrotrophic adenomas that the TSH fold rise is blunted, and note it's the fold rise we're talking about here, with virtually all patients, with just one exception, not increasing above a fourfold rise. Whereas with RTH-beta, we tend to see preserved, or indeed in some patients, exaggerated fold rises in TSH after injection of TRH. And again, you can see an almost complete separation, not quite, a little bit of overlap just from a couple of patients here. But this seems to be a very good test that's separating between the two. Similarly, the response to first-generation somatostatin receptor ligand therapy has also long been recognized as a potential route to separating these entities. So Paulo Beck-Pecos and colleagues many years ago showed that patients with resistance to thyroid hormone often showed very little in the way of change in either TSH, free T3 or free T4 following depot injections given every 28 days, whereas patients with TSH-OMA showed a quite nice drop, in particular in free T3 levels, often achieving a euthyroid state, as it were, with improvements in free T4 and also some, but not so dramatic, changes in TSH itself. And indeed, Philippe Chanson and colleagues have shown that this is a very effective form of treatment for TSH-OMAs, and indeed some patients with TSH-recruiting pituitary tumours can actually develop a form of central hypothyroidism, almost requiring a block and replacement strategy, on the basis that the normal thyrotrophs are still asleep and the somatostatin receptor ligand is nicely suppressing the tumoral thyrotrophs. What about back to our patient who had suspected TSH-OMA with no genetic cause identified for RTH-beta, but with an apparently normal MRI? Well, again, there are numerous approaches here to now being able to try to identify where these lesions are. And one of those is to use functional molecular imaging. We've spent a lot of time, for example, working with 11-carbon-methionine as a PET tracer. This is taken up by both normal pituitary tissue, but also quite nicely by thyrotropinomas. And here we can see in this patient's MRI, it's really difficult to discern the presence of a tumor. I can show you ultimately that this is actually where the tumor is, but I think it'd be difficult to call this when you're looking at the MRI on its own. But interestingly, on the first PET scan at baseline, there is tracer uptake, which is skewed towards the left-hand side. So this is a combination of some normal gland uptake, but also uptake by the tumor. Then after the patient has been treated with 3 months of somatostatin receptor ligand, not only does that normalize the thyroid function test, but in this instance, it also resulted in a change in the distribution of uptake of the methionine, which now became more central. And Dan Gillett, a colleague of mine working in nuclear medicine, was able to perform what's known as subtraction imaging, which is to delete this PET signal post-somatostatin receptor ligand from the original pre-somatostatin receptor ligand PET scan and produce essentially a subtraction or difference image, which beautifully localizes where this tumor was subsequently found to be at surgery. And this patient then went into complete biochemical remission. So this is an added entity now which can be put into the algorithm to help us to separate out RTH-beta and TSH-OMA. So going right back to where we started in this talk, it's always important to make sure that before we jump the gun, we've excluded any interference in free T4 and free T3 assays, indeed the TSH assay, and we've also thought about the potential confounding effects of drug therapy or intercurrent illness. But then once we've worked our way through and we're trying to distinguish between RTH-beta and TSH-OMA, there are a whole combination of different tests that we might need to use. Obviously, if there are affected family members, or of course we get a positive gene screen when we're looking at RTH-beta, but it may be that we need to combine a number of tests, both biochemical markers, dynamic testing, such as the TSH response to TRH, or indeed the T3 suppression test, or, as I've just shown you, hopefully, combinations of treatment, for example, with first-generation somatostatin receptor ligands, and, if needed, molecular imaging to complement standard anatomical imaging to help separate these. So really, to summarize, important that we review the clinical context. Once we're happy that actually we know what we're dealing with in terms of the clinical scenario, Then we need to talk to the laboratory and make sure that we're not looking at any form of laboratory assay interference. And thereafter, we need to think about specific conditions, which we may not be that familiar with and which we may need to speak to other colleagues about in order to help us to distinguish between conditions which are often only seen relatively rarely in our services. So I need to thank you for your attention, and I need to acknowledge all of my colleagues who contribute to all of this work, in particular, my long-term mentor, Chris Chatterjee, but also colleagues in biochemistry, and also Carla Moran, who's been working with us for many years and is now back working in Dublin. Obviously, the funders who support us, but most of all to the referring clinicians and patients, without whom we would not be able to do this work. And I'll leave you with some key references, which I think you may find helpful to complement this talk. Thank you very much for your attention.